it's really lovely to be here. Thank you so much. It's slightly daunting seeing all of you here, all from all across Scotland. But I'm really excited to get to know you a bit better later and hear more about what's going on. But just to start with, I've been asked really to talk on the topic of peer leadership. I won't introduce myself anymore because you know where I'm from. I guess I'm just going to ask, has anyone been to Sussex? I've got a few hands. Been to Brighton? Yeah. Okay, brilliant. Well, I'm really pleased to be here in Scotland, and I have been up here a few times, but I've been driving around for a few days. I've seen some great places, so that's really nice. But before I start, I just want to make sure that we're all kind of on the same page and we're talking about the same thing. Although if you have different thoughts, that's interesting. I'm happy to hear them. But in the paper that I wrote, I was very careful to define what we were talking about when we said lived experience. You do hear people just sort of saying, well, you know, I don't understand that. What does that mean? Some people say, I don't agree with that as a term. But I'm very much sitting happily with lived experience. And I started in the paper with the definition on the left, which comes from Louisa Byrne, who's in Australia and is writing a lot on this topic. And she talks about three essential aspects. So one is the life-changing or life-shaping individual experiences. Can you hear me okay at the back? Yeah. Two is the common impacts of those adverse experiences, so beyond yourself, the identification as a peer, understanding and application of the collective peer thinking and values. And the third is ultimately a unique, experientially developed knowledge base and a set of skills that can benefit others. And I think that's what Louise was just talking about when we're talking about peer leadership and all peers and what they're bringing to their work. So in the paper on the right there, which I wrote for IMROC, I took that a little bit further and talked a bit more about this skill set and what that might be. And actually in all the different lived experience roles we know, like peer support, peer trainers, peer researchers and others, it's the same sort of, you know, set of skills but used in different ways. It's a skill set that allows you to connect with others, to listen and involve other people to create change. And I think the change is the really important sort of word there, because that change can be at so many different levels. It can be at an individual level, it could be like in a family or you know, a social kind of network level, it could be an organisational level, it could be at a system level. And the focus of all the roles that we see in using lived experience is this experiential and relational knowledge. And the relational bit in peer support, when we talk about intentional peer support and using those skills of mutuality, reciprocity, etc., that's the relational part. And the goal of what we're talking about when we talk about peer leadership is to recognise this lived expertise, recognise it as an equal form of knowledge alongside those other accepted bodies of knowledge that could be clinical or managerial or operational. So I was just thinking to start with what peer leadership means to me, and because I think we probably all have variations of it, of what it means to us and how we use it in our particular systems or organisations or lives. And what I've really done at Sussex over the last kind of 8 years is using my experience. I was and now and am again a user of the services in Sussex. I'm always, every situation I go into, that's the lens that I'm looking through first. It's whether it's with just one other person, a group of people, whether I'm sitting there with the executive committee, that's the lens I look through first. So I'm using my experience, both lived and learnt, because I've had a career before I came in the NHS. I've got all sorts of other expertise and experiences. And I'm using that to build a strategic case for peer support or lived experience roles, whatever I'm focusing on. I'm working mainly to develop those roles. Getting the roles in the first place is one thing, but then how do you actually get them to be embedded, and how do you allow people to progress within those roles, to develop themselves personally and professionally, and develop the capacity for people in peer support roles to thrive and then to be leaders. That's all the role that I'm in, and that's a lot of work. There's also the collaborative understanding of the impact of peer support, which we neglect because it's kind of like it always comes after the effort you've put in to get it started. But it's so important that we start building more and more of a strategic case for why we're doing this, what difference it's making, a collective case that people can understand. And then lastly, I'm doing what I'm doing here, which is to join with other peer leaders. I'm joining up through IMROC with peer leader networks across England. I'm joining up internationally with peer, leadership people across the world. We are all coming together and building up this work. Just thought I'd show you this because it's a lovely visual. It's a little bit old for us now in Sussex, but we developed this, I think it was back in 2018, and it was our peer support charter. I don't know who it was who did the artwork, but I really love it. So basically, this was our way of trying to communicate across our system, including lots of our third sector partners at the bottom, what peer support was based on and what it's about. And you guys at the Scottish Recovery Network know all of this. You've got all of your own amazing visuals, which I've also used as well. But we had these printed in really massive posters, and we tried to get as many as possible in all of our clinical services. This work of communicating what peer support actually is probably a job in itself, isn't it? It's like a full-time job, let alone all the other stuff. And it is ceaseless, because as soon as you've got one team on board and they understand everything here on the left, and they're actually embodying it, and they're seeing the difference that peer support is making, some of those staff will leave and then new staff will come, and you've got to start again, because this is not the system has not been designed for this, as Louise said. The system only outputs what it has as an input, and this has not been the input. This is not in nurse education. This is not in medical education. This is different. This is new. So I would say that our work in Sussex is almost like a kind of constant round of education and readiness. I only have 2 people in my team, so it's a lot of work that we're doing, a lot of it online. We have 65 peer support roles now. We're talking about a lot of different clinical services. And it's almost like, when something pops up and you bash it down and then it pops up over here. So it's pretty constant. Our approach in Sussex is very much that peer support workers are employed mainly by the NHS and in clinical teams. So they are part of a multidisciplinary team. This is not the only model, as I'm sure you well know, and there are many other great models. But that's the model that we've gone for, and a lot of other NHS trusts in England have as well. So when I say we've got 65 roles, some of the other trusts like Central North West London, Midlands and others have got more than that. Some of them have got over 100 roles. But it's based on the same kind of framework, which is that you have a central sort of peer leadership team who are in effect like the professional leadership for peer support. Like OTs have professional leads, psychology have professional leads. So we're responsible for all of the framework around recruiting, training, supporting and developing roles. But all the roles are actually recruited and managed within clinical teams. So we're not directly managing that many people. But we do offer one-to-one professional or peer supervision to all of them. So as I said, it's I think when I first got started, we had about 12 roles, and they'd been there for some of them for over 5 or 6 years. But there's never been, in case you're thinking, wow, this is amazing, there's never been any plan for this. There's no strategy and no plan. And actually, if you look at the NHS generally, there are no workforce plans. I've tried to align what we're doing with other parts of the workforce, and they don't have a plan either. So this has been purely organic, really. Apart from, we've had 2 waves of external funding from NHS England, and that was for urgent care. So I think that was like 2019 and 2021. And as I was sharing with some of the other guys earlier, again, no planned approach to that. I was literally told one day, we're recruiting 20 people next month. Can you do the interviews, you know? So, but what we have got is a healthy situation with a lot of roles. It's gone down to about 65 now. We're seeing a sort of tailing off because of the financial climate. There's restrictions on us re-recruiting for any role within the trust, and particularly sort of in like my team, we can't recruit at the moment. But we have got a healthy number, and we've got a healthy network of peers, and I would say that's another thing that's absolutely critical. They meet in huddles, so there's in various areas of Sussex, which is quite big. They've got like a Hastings huddle, an Eastbourne huddle, a Brighton huddle, and then you've got these services at the bottom. So we've got people getting together, all the people from rehab, I think there's 6 of them, they'll get together probably online because they're dotted all around. The forensics peers have a really active peer-to-peer huddle and network. And the other thing that we do is really try and encourage people to develop the skills to mentor, and then we put them on the IMROC peer supervision course, which is not a great big course, but it means that they can run like kind of peer-to-peer reflective spaces. So we're trying to skill them up through that. As I said, some of the drivers in England have come from what was called the New Roles in Mental Health programme, and that included all sorts of things like pharmacy technicians and physical health, people who do physical health checks, but it also included peer support. The competence framework, that was an interesting one because I was involved in some of the meetings around that in London at NHS England in, I think it was 2019. And that was actually written by a group of people who weren't peers at all. They basically, I can't remember where they were from now, but they'd written competence frameworks for psychology. So they thought, well, we'll just let them do the peer support one as well. There's a little bit of an outcry about that. And essentially we all had to then like submit, you know, what we thought should go in there, and it was a long, laborious process. But through this also, we did, the most important thing is we got funding. So we got funding for training. So since 2019, every peer worker in Sussex, I mean, some of them have left, so it's probably nearly 100 have gone on training, which was run by IMROC, but is now a different provider. And we also had match funding for that. So the training itself was about £3,500. And if somebody went on the course, they gave us the same amount. So we used that in SPFT, in my organisation, to develop our capacity. We had some fixed term posts. We had a huge peer conference at the Amex Stadium in Brighton, and and used that funding, which is what it's for, to develop your organisational capacity. As I say, there has never been any workforce plan. The long-term plan gave a number for peer roles. It said, I think it was 5,000 or 6,000, and a target date, which we've passed. but there's never been any connection, as Louise says, to that long-term plan and what actually happens on the ground. So it really just depends where you are, which services are interested. It's driven almost entirely by the services saying, yes, we want to recruit a peer. And obviously we've done quite a lot of work to promote the idea, and sometimes there's direct funding, but it's been very piecemeal, but quite fast. Just to note, the apprenticeship, have people heard of that? Is that just an England thing? So the apprenticeship hasn't really taken off that much because it's very difficult to work out what the difference is between that apprenticeship, which is level 3, and the IMROC training, or the peer worker training that's funded, which is the same level. So a lot of people go, well, I've already done that. I don't need to do that, which is interesting to watch that space. So overall, I didn't know it was going to do that. This was the strategy that we came up with in Sussex. So it was just literally me and 2 people in my team saying, okay, we need a strategy for this. How are we going to support it? And it actually, we did it in 2021, and it took us up to this year, and we are just about to revise it. But it won't just be for peer support. We're going to include the other lived experience roles as well in Sussex, because we want to join them up much more than we have in the past. So we've got about 20 peer trainers in the Recovery College, and we've got about 5 or 6 people working in lived experience research roles. And then experts by experience who are not in substantive roles, but they work with the organisation to co-produce and improve. We've got nearly 200 people on our bank for experts by experience. So this kind of covered basically every stage that we needed, and I'm happy to share, it's a bit old now, but I'm happy to share it because there's a document that goes with this in terms of the structure and the frameworks you need to do the engagement part, which includes clinical teams, crucially. But we also run a short course for people who are interested in peer support, called Principles of Peer Support, or POPs, so that they can actually learn more about peer support, and a lot of them find it quite transformative because it's the first time they've learned about peer support, and then consider whether they would actually want to go into that role. We do an inclusive recruitment guide for people. We've done a lot of work with our HR teams around things like reasonable adjustments and making sure that the process is as smooth as it can be. And then when it comes to recruitment, one of the biggest things that we do is work with the team around the role plan. So we have obviously job descriptions, and they're like across the board, they're the same across the whole trust. But the role plan is the really critical bit. What is that person going to be doing each day, and how is it going to integrate into the team, and how are the patients going to know, or the service users going to know, what the peer support person does, and how are the other staff going to know? And we're trying to head off some of those issues you get when you recruit peer support roles, and actually people are either confused by it, or they try and turn their role into something different, or they just ignore it. So we do a lot of work around that stage and the induction process as well. The training I've talked a bit about. We do extra top-up training, which is kind of on demand, if you like. So we say to our peer workers, what do you feel like you need to know more about? And sometimes they'll say, oh, I don't know, trauma-informed practice, or how to write in notes, or boundaries and professional boundaries. We did a really good course on that recently. So then we put those on every couple of months. The competency and practice bit is another way that you can really get other people to understand what the role is, because it's all very well having a job description, but you still get people, including peers themselves, saying, I don't know what I'm supposed to do, or I don't know what they're doing. What's my job? So we did a lot of work we recruit people at the band 3, we call it, which is the kind of lowest level, and then we mapped developing competency to the next stage, which is band 4, and using that competence framework. and then have like checklists for people to say, oh, okay, I have done a bit of that. You know, I can describe how I use my skills in that way and demonstrate. And we do this with their managers. So their managers may be like the team lead, they might be, you know, a senior nurse or whatever, and just really make it explicit what we're asking people to demonstrate, which some people find quite hard, don't they, to do that. Clear routes to progression. This is a bit of a challenging one because we don't really have the budget for any more senior peer roles, which is why we're all here talking about it, isn't it? If we could employ people at the next stage in local places and local services to supervise, you know, if we employed them at band 5 or 6, I would, you know, we could create 10 roles tomorrow. There is definitely capacity to do that, but there is no budget or willingness at the moment. The only way we can do that is if we got some funding for, say, 4 roles, but we turned one of them into a more senior role. And I think that might be the way we go. We do see some of our peer workers going on to other routes. So we've had people going down into social work, doing the apprenticeship, OT, and nursing. We've had one. So this is if you talk to our peer workers now, if they all came in, that's what they'd talk about. There's nowhere to go next. I'm going to skip past that, I think. I'm just going to talk a little bit. I might have to run over 5 minutes. Is that all right? About stepping back a bit, so I've stopped talking about Sussex so much, but about why peer leadership is needed. And this is really the first part of the paper that I wrote. The first part is why. Why are we doing this in the first place? You know, what's the impact that we're hoping for? The second part of the paper is how. So if you're interested in different roles, in an organisational strategy, that kind of thing. But I think we have to establish the why, because I think it's pretty clear to us in this room, but it certainly wouldn't be clear to a room of other people. It just really wouldn't. And I don't know about you, but if people ask me in the pub what I do as a job and I tell them, they genuinely look quite confused. They're like, why would you do that? Sorry. So that cultural acceptance of why and how peer support adds value does not exist in most traditional healthcare systems. It doesn't exist in the England system, and it sounds like it doesn't exist in the Scottish system. It's because it's based, like I say, it's a system that's had these inputs for decades. All the knowledge and all the skills has been based on academic learning and training that's mainly through that medical or scientific approach. So you can't even really sort of blame people for it, can you? It's just that's what you should expect. That's what the system is going to output. What it leads to, bottom left, is a lack of focus on patient experience over safety. So quality is how healthcare is measured. Quality is made up of safety, effectiveness, and experience. And it genuinely goes in that order. So I've sat around a table with our exec committee looking at the quality measures. I told the guys earlier that the reason they were looking at it is that the meeting that they used to do the clinical governance and to look at quality of the organisation has started going over 3 hours. That was their problem. My problem immediately is, why are all the measures about safety? All of the measures that they're focusing on are about safety. They're the number of deaths, the number of ligatures, the number of incidents, all the, terrible things. And actually they're supposed to be focusing on effectiveness and experience as well. But when they come to experience, they sort of scratch their heads and go, well, you can't really measure it, can you? Well, we're, in this room, we're experts in experience. So we can bring a lot to this. We can give really great insights into what people's experience is like and how if you make people's experience better, even if they're really ill, even if they don't know they're ill, even if they've got their life is falling apart, if you make their experience better, whatever you offer them will be more effective. It just will. And if that's more effective, then you won't need to worry about the safety quite so much, because those things are less likely to happen. So this comes down to like that unquestioned use of the medical model over all this time, despite the fact there's very little evidence for it, especially in mental health. So we see misdiagnosis all the time, and we see poor treatment because everybody is just going, well, what does the doctor say? Well, the consultant said we've got to do such and such, but they're not thinking about the person's experience. So that means not only does the patients feel done to, but so do the staff. So when you see resistance in the staff, it's because they feel done to by the system they're in. And their experience isn't really tended to either, is it? And have a look. I don't know, obviously you're all in different organisations, but if you've got an NHS, like you can see their staff survey and their staff experience, it will probably be quite shocking. So where that resistance comes to change is because you're coming in and possibly making their lives even worse by changing things. Do you know what I mean? So they don't trust change because they've been through 25 different changes and they don't want to go through any more of that. The other thing that's really, really important about peer leadership is to start to demonstrate some of the differences that it can make, the impact and the change that it can result in. Not just through that medical lens. So yeah, for some of us, our clinical recovery was incredibly important. And some of us earlier were talking about medication, and actually can be really important for some of us, can't it? To get back to like who you were because you've been really unwell. But the change that we've gone through our recovery is enabled by that potentially or not. But it's the most important thing to us. It's the most important thing is the change and the things that we've been able to do because we're starting to come through a recovery process. And once you have come through that and then perhaps something happens and you start to feel worse again, the pain of that, because you think, oh God, no, I don't want to go back to where I was before. And that's what's so important to us, and that's our experience. Thinking about changes that we can make as peer leads, and I've talked about that the system, there's a really good book by a guy called Neil Armstrong, not the astronaut, talks about the mental health system in the UK. I really recommend it, as an accountable bureaucracy. So everything that the system is generating is to regulate itself. And as long as you've checked, people say, oh, you've ticked all the right boxes. Well, it genuinely is like that, isn't it? But on a massive scale. And each system is perfectly designed to give you exactly what you're getting today. So that's where our change is needed, not just at the top of the iceberg model, to actually transform things. It's actually looking at, it says down here, the social paradigm, mental models and world views. And that is trying to get people to understand that if you're mentally not feeling too great, you might not just need a doctor or a psychologist. You might benefit from something else. And I think that's very difficult at the moment for the majority of people to understand. So that's our work as peer leaders, is to demonstrate that something else actually can really help us there. We often talk about a lack of money, and there really is a lack of money, especially where I'm coming from in Sussex. I'm now doing 2 jobs. So one of my colleagues has left. Lots of people have left. We've had lots of redundancies, lots of restructures, But I really love this quote. It really put it like there for me. And this is Dr. Vikram Patel, who's Professor of Global Health, and he wrote a lot for the World Health Organization. So he says the solution is often thought to lie in more money and more mental health professionals. Remarkably, however, despite the amount of money spent on mental health care and the availability of mental health professionals in high-income countries, or mental health research as currently imagined, the crisis has not eased. So this system, however much money and medical expertise you put into it, is not actually ever going to solve some of the problems. And the research that we're doing that is generally coming out around mental health is probably not actually focused on the right things or done in the way that's actually helping us. So I've also had in Sussex, I've been working on something called PCREF, which is the Patient and Carer Race Equality Framework. And so that's looking at the fact that black men especially face major inequalities in mental health, and they're 3.5 times more likely to be detained under the Mental Health Act. And I saw some really interesting paper that came out recently, and it basically said for over 2 decades our knowledge of why this is happening has not advanced, because we're just looking at it through the same lens. But they involved black men and they listened to their narratives, and there were some strong themes coming out that had never been written about before. So it makes you realise that we just need to think about doing things in a different way, otherwise we will just replicate these problems that are affecting people every day in their lives. I think I'm not sure I'm going to go through the next bit because I'm running a bit on time, aren't I? This was some of the challenges that we have every day with our peer support roles, which I'm sure are some that you're aware of. I've put at the bottom lack of investment in peer leadership roles, because even though I'm in my role and I have 2 senior peers in the team, we're not going to get any more funding at this point. We're not going to get any more funding, maybe even less. So it's starting to go down. And that is another reason to maybe think about doing things in a different way. So what we do locally, a lot of, is quite strategic. We're translating the challenges for our peers into clear recommendations for our organisation. And I think in Sussex we are lucky that we have a voice and we're able to do this. I can present this kind of thing at quite a high level in the organisation. It is listened to. It's not easy. We've got a neighbourhood mental health team transformation process going on, and for 3 years I've been trying to get funding for roles in those teams, and I haven't got it yet. One of the things I'd say to you is don't give up. I think I want to give up quite regularly, but sometimes you sort of just think, this is ridiculous, I'm going to give up, and then something will change. And they'll be like, oh, have you got a proposal for the roles in the neighbourhood mental health teams? I'm like, oh my God, I've been trying for 3 years. These are the last bit. So in the paper, this is based again on Louisa Burns' work on the left. When she talks about lived experience and a sort of strategy for an organisation or a system, she talks about 3 things. So literacy, expertise, and presence. So presence is that stuff around actually inclusive recruitment, making services accessible for people to actually come and work in them, making your workforce diverse so it reflects the community that you serve. Looking for people with lived experience in every role, doesn't matter what the role is. We do that in Sussex, so every single job description has it as desirable. You're building up the number of people who are working in the organisation who get it. The literacy is the bit where the whole organisation or the wider organisation actually needs to understand why you're doing this. So it's talked about, and stigma is challenged regularly. And with literacy also, it's about how does each team or service or professional listen to the experience of the people using that service. That should be part of their objectives. It should be demonstrated. just like their numbers on discharges or whatever it is. Expertise is the people you recruit because if they've got lived experience and they're going to use it in whatever way it is. But you make that as many people as possible. They could be working in complaints. You could have all sorts of roles throughout the organisation with people who are using their lived experience in their role, or it could be obviously peer roles. And the reason we're doing this is that you're demonstrating constantly the value of lived experience, and you're demonstrating it through embracing that diversity of thought and making experience like number one thing you focus on. So a team meeting, or when you talk about, referrals or handovers or something, you talk about it through experience lens first. So you zone in on that rather than zoning in on people as problems who need to be shipped about like parcels. And then you also use lived experience to really drive collective action, and that means people who in peer roles and people in non-peer roles, all the people who want to improve things working together, and that energy you get, which I think Louise was talking about, the energy and the momentum you get from people saying, I know how I can make this better. And you really embrace that collective action.